Assalamu alaikum. I'm Dr. Motia Noor. Today I have again been here with another new class, new topic. So this time have prepared two stations which are really small stations. Okay, like within blink of eye it will end. This kind of stations, but these two are really important stations. Like these two station does come with another stations as like some of the questions or the whole station does come but with the ending of another station. Okay, so today I have two stations with me. One is abscess, second one is osteoporosis. So abscess, here I would like to say one thing, uh, that this one thing this topic abscess, it does come with many of the topics, sometimes like with gallbladder, some like any kind of stations. Okay, this abscess does come with as the ending or as like a tail. So right now here we are just talking about abscess as a station, but next time when I will come with another mock, that time I would tell you like how we are like putting the questions with another stations as a tail of another station. So today, uh, here, oh, this abscess, it not only comes in our pathology, but also in our procedure station, okay, where you have to like do an incision and drainage of abscess, where you have to do two things. One, you have to do the procedure, and another one is you have to give some answers, okay, at the same time, simultaneously. Okay, so firstly, here, the patient came to you with forearm abscess. Okay, and there will be this picture. So, firstly, they will ask you what is an abscess. So, that is a focal collection of pus that may be due to a seeding of pyogenic organisms into a tissue or by any kind of secondary infections or any kind of necrotic foci. So, focal collection of pus due to seedling of any kind of pyogenic organisms. What could be that? That could be bacteria, that could be virus, that could be fungus, where it will be into a tissue. What will it cause? That will cause infection. And from infection, what will this happen? Multiple time infection and inflammation. It will cause necrosis of that area. Okay, when there will be necrosis, so that time it will cause, later on it will cause something, a liquidy material, which is called a pus. So next question is, what tissue is the wall of an abscess characteristically composed of? So I would like to say here that abscess is infective, okay, but the wall in which the abscess does stay, it is not infective. It is, but it is called a pyogenic membrane. Okay, it is not infective, but inside that the abscess, that is infective. So there the layer or the covering which is surrounds the abscess, it is called granulation tissue. Okay, so so what is the question? So what tissue is the wall of an abscess characteristically composed of? That is composed of granulation tissues. Okay, and here it is not written here, but like what is like this granulation tissue formed by? That is like lymphocytes, then fibroblast, then what capillaries, small venules, all those things. Okay, this is causing this pyogenic membrane. Okay, it is called pyogenic membrane, but actually it is not pyogenic. Okay, inside is the pyogen, inside is the bacteria or infection or inflammation. So this is the question. The next question, what is present inside an abscess? So I have, in the definition, we have said that seeding of an pyogenic organism inside a tissue, and then multiple time there is infection, inflammation. This is causing necrosis of the inside of the tissue, and that is causing this abscess. So here centrally there is largely necrotic region, which is rimmed by a layer of preserved neutrophils with the surrounding zone of dilated vessels and fibroblast proliferation indicative of attempted of repair. So What is inside the abscess? You are going to say all these things. The definition. Then you will say that it is surrounded by a layer, which is like composed of neutrophils, lymphocytes, the dilated vessels, fibroblasts, all these things. That means both you have to say the pyogenic membrane. What is it composed of, and inside of it. Next one. What is pus? Pus is the product of acute inflammation, and it is composed of what? Cellular and fluid and exudative phase. All these things. Okay, there will be some cells, there's neutrophils, lymphocytes, then the fluid and the exudates. Next, organisms causing abscess. So abscess, it is in broad heading, it is composed of two things: bacterial and non-bacterial. So in bacteria, you're going to say at first step aureus, pyogens, epidermides, all those things. But in non-bacterial, you're just going to say in broad heading. That is what? There could be viral, there could be fungal, there could be parasitic, all this. So if they ask one simple test to detect the cause of abscess, that will be what? That will be gram staining. Next question. What is the cause of fever in abscess? So when a patient do come to us, when you're going to take some history, he will say there is a swelling. Suppose in this case in the forearm there was abscess. So the patient will come to you with the complaint of there was a swelling. Sometimes there could be some suppuration. Then he will say locally that is painful. The temperature is raised, and he will also tell you a history of fever. Or we do ask him, like, do you have any kind of fever, raise of temperature in this meanwhile, in this time frame? So what is the cause of fever? So when there is an abscess, that time our body's neutrophil do get there, and it starts fighting. Okay, so these neutrophils and cellular debris, this causes a response in our body's immune system. That time there are some things like TNF, interleukin 1, interleukin 6, means tissue necrotic factor, interleukin 1 and 6. These are activated. Okay, then this stimulates the prostaglandin, and this prostaglandin then stimulates our brain hypothalamus. Okay, it causes the hypothalamus temperature. It increases the brain's hypothalamus temperature center. Okay, that's why a patient then have fever. So at first, if there is abscess, there will be neutrophils, lymphocytes, all those things. Then from there will be tumor necrotic factors. There will be tumor necrotic factors, interleukin 1, interleukin 6, which will stimulate the prostaglandin synthesis. This will cause the brain's this will stimulate the brain's hypothalamus, which will cause the raise of the temperature set point. So next question. Here I have showed a what is a diagram of how the temperature is getting raised. Okay. So next one. Define cellulitis. So what is the difference between cellulitis and abscess? When there is something organized, okay? There is a covering, and inside there is a suppuration or pus or inflammation which is fluctuating, which is swelling. That is called abscess. But before that, if that is not organized, okay, if there is no cavitation, there is no collection of pus, if that is a spreading thing, that time I will call it a cellulitis. Okay, so a spreading bacterial infection of the skin which affects the dermis, subcutaneous fat. Here there will be redness, warmth, swelling, and pain. Okay, so it will be it will involve a vast area. There will be not there will be no like collection of pus. There will be not a covering, and the patient will have when it will affect the patient's certain body part, it will involve a bigger area. Okay, so again there will be a bacterial infection which will affect the skin, the dermis, and subcutaneous fat, and it will characterized by what? Redness, warmth, swelling, and pain. Then we have read it like rubor, dolor, calor, and functionless, those things. Then the difference between abscess and cellulitis. So normally abscess is caused by Streptococcus aureus, and cellulitis is like all this like streptococci, which involves in is in group A, those. Then in case of abscess, the organism secretes coagulase, and in case of cellulitis, it is causing fibrinolysin and hyaluronidase. Okay, and this fibrinolysin and hyaluronidase, these two are causing a widespread. It is causing the widespreadness of the organism, or when we are calling this cellulitis, it is involving the whole thickness, or like from skin from like here to here. It is causing. It is caused by the rapid spread. It is due to these two things, fibrinolysin and hyaluronidase. Okay, then abscess, it is localized, and cellulitis, it is diffuse. In abscess, there will be a central zone of necrosis. That's why we are calling this is an organized thing. Okay, and there will be the liquid things. And in case of cellulitis, it will have an extensive area. At first, it will involve the extensive area. If we are not treating the patient on due time, then it will cause involve the whole thickness, and it will cause progress and will cause necrosis of the extensive area. And abscess, it forms rapidly. Most of the times, our patient do come to us with like she or he have a history of 2 to 3 days. Okay, so it has a rapid formation, and the color is the content is thick and yellow. And cellulitis, it is slow formation. That whenever normally the patient will have there will be thin discharge, and sometimes it causes RBC. It is composed with RBC. 1 second. Okay. Next thing, when to give antibiotics in abscess. So here we are coming like that thing. It's whether it is abscess or cellulitis. Okay. If the abscess is organized, okay, if the patient, if there is like formation of pus inside it, so at that time we are not going to we are going to give antibiotics, but it would not work as good as it would have worked before it is not localized. Okay, so when a patient is already complaining of like formation of pus in pus, that time antibiotic would not work as much effective as before. So when to give antibiotics in abscess, antibiotics are indicated if the abscess is not localized. Like in case of cellulitis, antibiotics are working really well because that thing is not still organized or like still not localized. Or if we are giving, we have to drain it, then we are going to give antibiotic. Okay, so the next thing, or the cavity is not left open to drain freely. So 2 things, if it is not localized and after it is drained, you are going to give antibiotics, sorry. Then what are giant cells? So when there is any kind of abscess, it means there is involvement of microbes, any kind of bacteria. So to attack that or to destroy that, we have to give our body turn some macrophages and neutrophils against them. Okay, so when the macrophages are activated and multiple macrophages are fusing together and attacking those bacteria or viruses, that time it is called a giant cell. Okay, and later on it forms the granuloma. Okay, and beforehand we have read what is the covering. That is we have here granulation tissue. Then later on this granuloma, then these neutrophils, this lymphocytes, all these things are causing this forming this wall. Okay, later on. Okay. Okay, most common cause of granuloma formation. So at first we have read the fusion of multiple macrophages, activated macrophages. And most common cause, it will come in our mind, is tuberculosis. Okay, next question. Causative agent of microbacterium, causative agent of tuberculosis, that is Mycobacterium tuberculosis. Then the type of stain. We normally do gel nasal stain, ZNS stain. What character changes you will see in a lymph node affected with inflammation? So any kind of bacterial or viral infection or inflammation, we do, whenever we do any kind of histopathology, it will show or ultrasonography, any kind of thing, it will show reactive follicular hyperplasia. Okay, and from here, this lymph node, there was in some other stations, there has been some questions like what is the anatomy of lymph node, how it is draining. There are multiple questions regarding this, which we will discuss in our next mock exam. Okay, when you guys will be prepared and we will have some question answer session. So here our first station is ending. It is a really small station, but it's a really important station, okay? Because this is not only coming in pathology, it is coming in multiple stations of pathology and also in our procedure stations, okay? When you are doing the procedures and they will ask you both all the questions together, okay? Where they will ask, you are going to do your procedure. With that, you are going to answer their questions. And next question here. Oh, here I would like to say another thing, that is with abscess, they will sometimes they have two station compiled together, like tuberculosis and abscess together, or like abscess and gallbladder cancer, pseudomembranous colitis, all these three things together, or from inflammatory bowel disease and abscess, all these things, okay? Like they could jump from anywhere. So this was first station. Then the second station, pathological fracture. So this station was something interesting, because this station did come when I like last year, January, I sat for exam, and that time we had a 4-day exam, and maybe in 2 like different days this thing does come, but not like this. Okay, pathological fracture, this do come with in my station, maybe with thyroid. Okay, with a thyroid station, this does come with mine. And then in another station, maybe with that thing, osteoporosis, the giant cell arthritis, that station. Okay, and another one, sometimes this station also come in critical care station. So this pathological fracture is really important. Really, it is a really, really important station. So here, you will have like different kind of scenarios. At first, you have to read this very carefully. When you will be outside, you will have 1 minute before entering your station, and in that 1 minute, you will have a paper in front of you. Okay, there will be a scenario like this. Okay, and the scenario sometimes could be really big, but you have to read that really carefully, what it is written there. Okay, because that thing, according to the station, according to the scenario, you have to answer inside the station. Okay, like here we are talking about a young female, but sometimes there could be like it is called an old female, elderly female lady, or sometime a patient is having in kind of the patient is undergoing a surgery. So just be really, really careful. Okay, read the station, read the scenario before getting into the station. Okay, and oh, sometimes it could be like that. You're thinking, okay, maybe this after reading the scenario, you're thinking, okay, maybe this is a critical care station. When you're getting in, oh my goodness, this is not critical care, it is pathology station. Okay, this thing happened with me. When I was inside the station, I thought at first it maybe it is a pathology station, but later on I found out that no, it is not a pathology station, it is a critical care station. Okay, and maybe I was confused due to this, like this pathological fracture. Maybe then he went to something else of critical care station. So here the scenario was a young female who was cycling, developed pain in her thigh soon as she put her foot on the ground. Then the X-ray showed fracture shaft femur with hypodense shadow. Okay. Then the questions will start. What is a pathological fracture? So when there is any kind of fracture without any kind of huge trauma, okay, due to any existing pathology, okay, the person does not know he had any kind of bone pathology, but just due to any kind of sudden fall, she is or he's having a fracture, then he or she will find it, okay, like I had this problem for which I am having this fracture. Okay, so what is pathological fracture? Bone fracture which occurs without adequate trauma and caused by pre-existing pathological bone lesion. Okay, so just a young female lady in the scenario is say a young female lady who was just cycling and just fall, and then she, after seeing the X-ray, she found out what she's having a fracture shaft femur. Okay, so it was not like a huge trauma for which she's having this. So just not an adequate trauma. Next one, what is the causes? So there could be two type of causes. First one is non-neoplastic. First one is neoplastic always. Second one is non-neoplastic. So first one is like a neoplastic. We're saying like any kind of tumors, like multiple myeloma, which could be think or like sarcoma, any kind of things, osteosarcoma and all those things. Then, or it could be metastatic, okay, like from prostate or from breast, those kind of. And non-neoplastic, there could be like what? Osteoporosis, osteomyelitis, osteomalacia, Paget's, bone cysts, osteogenic imperfect radiotherapy, all those things. Okay. So, can you just tell me one thing? If there is vitamin D deficiency, what will happen in a young child, and what will happen in an elderly lady or elderly person? Is there anyone? Okay, so normally if there is like vitamin D deficiency, we will find out that like in the case of younger babies or younger children, they will have this thing called rickets, and in elderly they will have this osteomalacia. So here, like when I was reading this non-neoplastic thing, it does hit in my mind. Okay, so osteomalacia. Then 5 possible primary sites for metastasis. Okay, I have memorized this by BBRTP: breast, bronchus, renal, thyroid, prostate. Okay, so this is a really important question. Next one, brain tumor casting sclerotic metastasis to bone. What is sclerosis? Means the bone is getting hardened. Okay, the bone is getting more and more harder. So normally this is due to medulloblastoma. Then in this patient, a fixation was done. Okay, so like without any cause why the patient is having this fracture, we have to get out the cause. What will we do as investigation? We will do bone biopsy. Okay, then it is another thing. There was a pathological report. There was a typical bland appearance which was follicular cell. What is the probable location of the primary tumor? Okay, so out of nowhere, they are saying this is follicular cell is coming. So we have where we have studied this follicular, parafollicular cells, thyroid. Okay, and here in this thing, before question is like mention 5 possible primary sites. Means this patient is having a metastasis maybe from thyroid. Okay, as they're saying like follicular, so we have to think all those things. Okay, it could be papillary, it could be anaplastic, it could be follicular, then it could be what else, all those things. Okay, medullary. Okay, so pathological report, it is showing what? Follicular cell. So what is the probable location? It will be thyroid. We have to correlate. Then next one, we have done FNSC of the thyroid but unable to differentiate cancer. Why? So thyroid is a really small structure. And we have in the before the bone biopsy or that histopathology report is showing what? It's follicular cell. Okay, so after seeing the follicular cell, we are guessing it to be a thyroid gland. Okay, then we are doing FNSC and it is not showing cancer. Why? But we are suspecting most probably it will be cancer. Why not? So here in the question, the answer is like FNSC means fine needle aspiration cytology. Okay, it is only talking about the cell, not about the tissue. Okay, so suppose we are taking a we are doing this FNSC from this side, not this side. Okay, maybe the right lobe is not involved, maybe the left lobe is involved, or and also when it is called cytology, sometimes that cell is not adequate to tell or to differentiate whether it is a cancer or not. So this is the thing. Malignancy is determined by capsular and vascular invasion. Okay, means we need a bigger tissue, which need histopathology rather than a cytology. Then next question is, as we have done FNSC, at that place, it is not say that cancer. What next investigation we could confirm that there has been a thyroid metastasis? That would be radioactive iodine scan. It will be hyperactive in intake. Then the next question is, what are the other site of ectopic tissue other than head, neck, and thorax? Okay. So here, it could this tissue could be found in somewhere else, or like we have read that there could be there are three types of cell layers, what are those called? If all the three layers, epithelial, endothelial, and mythelial, those three things. Okay, so wait 1 second, I will just. So when there are three layers involved, okay, so that time teratoma means is what? Like there could be anything in anywhere, okay, like hair inside our ovary or tooth inside our ovary. So this is that thing. What are the other sides of ectopic tissue than head, neck, and thorax? So that will be ovarian and testicular teratoma. Oh, and this station, this pathological station is really important because two stations are combined normally. That is this pathological stations, and another is thyroid station, and either pathological stations, and another one is what? That same thing, giant cell arteritis station. So, which thyroid carcinoma will show no response to iodine uptake? So I've told you guys earlier that thyroid are like form of two cells, like follicular, parafollicular. Okay, parafollicular, as those are high, not mostly not, as thyroid is mainly formed by follicular cells, but medullary thyroid, which origins from the parafollicular C cells, so that will not respond to iodine uptake. Okay, so next one. Okay, here this station, it is not relevant with like same thing, the pathological factor, but it is like a thing. So suppose this patient is have need to have a blood transfusion prior to operation. So what test you are going to do? Or like saying here it is said that a patient is a O positive patient. What test you will do? You will do two kind of tests. One is ABO blood grouping, and another one is RA striping and cross match. Okay, so ABO to determine that thing, A or B or O, and positive means RH group. Okay, and this cross matching before to see that if there is pre-existing antibody in that patient's body or not, whether that patient's own antibody will uh, fight against his that newly transfused blood. Okay, so next one, define hemolysis. So that is what? That is this rupture of RBC. And when there is rupture, then the cytoplasmic contents those fluids, those cells, all those things will, when that will flow into the blood, into the fluid, it will cause called hemolysis. Okay, so rupture of the RBC, it is called hemolysis. The next question: if the patient is telling you his group, will you do cross matching still? So suppose a patient, normally this happens to us in our daily life, in our daily working life. A patient is all the patient normally comes to us, yes, I do know my blood group, it is A positive, it is B positive. So when still we are saying no, I'm going, do you have any papers? We are to ask them, do you have any written papers? Then he is saying no, then what we are saying, so we have to do again cross matching. Then he is saying like, but I know my blood group, why you are saying this? Okay, then you have to say that I'm sorry to say, but we do need documents, because this, if we are giving blood transfusion without knowing your group, you are telling us that I know you're correct, but still without knowing your group, there could be two things happening. Okay, that is, as we are not sure whether this is your actual group or not, if we transfuse the blood in your body, there is some antibodies which are preformed in our body, or like our own antibodies. If the blood is not the same group, it will attack that blood, and that will cause a massacre inside the body. Okay, that will cause this acute hemolysis, or DIC, all those things. It is dangerous to your life. Okay, and also what, another thing for cross matching is that we have to see if the patient was previously had a transfusion, there could be preformed antibodies. Okay, so that could act against the antigen of the donor. Okay, so and that will again cause the hemolysis. So what we will say, yes, to determine if the recipient had any preformed antibodies against any antigen on the donor's side. Okay, so next question is a really important question: complications on complications of incompatible blood transfusions. So at first, what will happen immediately? Like there will be febrile, acute hemolytic. Okay, or what? There could be febrile non-hemolytic transfusion reaction. There could be delayed hemolytic transfusion reaction. There could be transfusion related acute lung injury. All those things, and you have to tell this. You have to memorize this one. It is a really important question. Okay. This thing, Burko's triad. Okay, these do come in our station every now and then. It is composed of three things: venous stasis, hypercoagulability, and endothelial injury. When there will be the venous stasis, this venous stasis to venous is causing the more cell to like being at the same place for a long, for a more than normal time. This is causing this hypercoagulability, and this great number of cells, then causing this what, endothelial injury. Okay, and this will then spill in the blood vessel or in outside our body, not our body, outside the blood vessels. Okay, so what is the Burko's triad? This does come like directly. What is Burko's triad? So that is three things: venous stasis, hypercoagulability, and endothelial injury. So next one is pulmonary embolism, which is the like where this thing is coming, the Burgos triad. So normally, what is pulmonary embolism? When the vein, somehow the embolism thrombus is getting dislodged and going to somewhere else in our body, it is causing thromboembolism. Okay, and what is pulmonary embolism? If somehow this thrombus dislodges and goes and stuck in our lungs vasculature, it is causing pulmonary embolism. Okay, so what is that? Pulmonary embolism pathogenesis is primarily driven by the venous thromboembolism. So normally, where does this clot dislodges from? In our, especially in our legs, there are like two type of system, venous system, like a superficial venous system and deep venous system. Normally, this happens in our deep venous system, like in our cuff muscle or in our pelvis. In those places, the clot somehow dislodges, and this causes pulmonary embolism. So a clot forms in the deep vein via Burkitt's triad, and then it dislodges. Okay, and what is this Burkitt's triad? That thing. If there is like the venous is getting stasis there somehow, for some reason the blood is staying there for longer time than normal, that is causing their hypercoagulability, which is causing this endothelial injury, and somehow this hypercoagulate, those thrombus is getting somewhere else. It is dislodging, and then it will go back to our right heart. Okay, and from what happens? So from right heart, the blood goes to our lungs, and then from lungs it goes to the whole body. But here is the problem: when it goes to the right lung, and then from right lung to pulmonary arteries, it goes into our lung. There this thrombus somehow just plugs or clogs in some of our really microvasculatures. Then this causes this there, it causes this obstruction. Then this all these things these drastic problems starts to arise, like there will be obstruction, vasoconstrictions, there will be impairment of gas and exchange, which will cause this pulmonary embolism ultimately. So this was this question, pulmonary embolism. So here, normally this kind of scenario does come, like a patient is suddenly, she's having what the patient is unable to breathe. Okay, and this thing, and suddenly she collapses. Okay, what will be the cause? So mostly this there will be a scenario, and then like this kind of scenario, that she has a fracture or something. If there is like saying there is she's having a fracture, and then suddenly she collapses and dies, there will be two scenarios. One is pulmonary embolism, and another one is what? That is fat embolism. Okay, so this pulmonary and fat. The next one is causes of osteomalacia. Okay, earlier what we read, I just discussed is one thing, that is there could be two type of things due to vitamin D deficiency. One is rickets in younger patients, and another one, younger means child, in case of child and adolescent, child actually rickets, and in kind of elderly relative, what could happen? That is osteomalacia. Okay, so what is osteomalacia? For some reason, there is like vacuole or loosening of bone. Inside the bone, there is like vacuum. So what could be the causes? Why the bone is vacuumated? That could be like many causes. Firstly, if the patient is on steroid, okay, steroid causes what? It decreases the bone mass. Why? Due to osteoclastic activity. Another one is like the patient is prolongedly immobilized. Okay. And then what? Renal failure. If there is renal failure, there is more and more the means the calcium is not what is that called, reabsorbing in our body. It is excreted from our body. That is causing osteomalacia. And ultimately, and lastly, is the vitamin D deficiency. So next question. But this causes of osteomalacia, yeah, we have talked about this in our previous class, which was what is that? Osteoporosis. There was a lot, many more other what is that called? Examples. Next one was still osteoid. So normally a bone is formed like kind of with formed by two things. One is like organic, another one is inorganic. Inorganic is what? Calcium, phosphate, all those things. And organic component is this osteoid. Okay, it is a protein mixture. Okay, which is secreted by what? The osteoblast. Osteoblast means what? Blast means built. I have always remember blast build, blast build, and see the another one is class, which means kill. Okay, so protein mixture which is secreted by what? Osteoblast. And as osteoblast means it is building something. Okay, this is causing what? This is building what? The organic matrix of the bone. Okay, before that I have just seen bone is form of two things: organic, inorganic. Or inorganic, there are like proteins, which is that protein is this osteoid thing. Okay, so bone is formed when the osteoid is mineralized. Okay, at first this osteoid is formed, then it there is reaction with calcium and phosphate, then this bone is formed by the help of osteoid. And then this osteoid, what is the importance of this osteoid? Okay, so we have already read like osteomalacia and recurrence. Okay, this osteoid, it is for making the protein component of a bone, which later on binds with calcium and phosphate and making this bone. Okay, and this leads, if there is a failure of osteoid, which is causing what, osteomalacia and rickets. Okay, then another thing is this amyloid. Okay, and here in normally we have read in our MRCS part A that like amyloid AL, all the six. So this amyloid, these are sometimes deposited in our different different parts of our bodies, like in our bones, in our heart, sometimes in our lungs, in our kidney. So normally when it is deposited in our bones, it is called amyloid AA. Okay, and then why it is not, it could not be removed from our body? Because in our body there is not the specific enzyme to degrade this amyloid. Okay, that's why uh, this cannot be easily removed from our body. And another is uh, also the kidney, like there are some here this amyloid is a protein. Okay, this kidney, it cannot excrete this protein, so most of the time this amyloid stays in our body. Next one, pathogenesis of fat embolism. Okay, so here I was saying, if the scenario says the patient is having a fracture, so you have to keep it in mind. And if later on the examiner do ask you, or suddenly why suddenly the patient does collapse. Okay, and you are seeing, okay, the patient is having a fracture. You are also seeing, okay, there the patient undergone a operation. So your first thinking will be, it may most probably it will be due to fat embolism. Okay, so what is the pathogenesis? This fat embolism, depot-derived fat embolism, where does it arise from? It arises from the disruption of the fat content. Okay, why? Usually because of a trauma. This, due to this trauma, this fat is directly entering into our bloodstream, and same as pulmonary embolism, this is going into our right heart, and then it is it is stopping or plugging inside our lungs or somewhere else, and this is causing shutdown. Okay, uh, this is the thing. This is the pathogenesis, and this is enough to say. And next one, this ESR thing. I don't know, but this ESR, it is really likable question. Every uh, sometimes in not a it is an unusual question. Okay, explain how to do ESR. Okay, it does come here, and also in maybe in aortic stent infective endocarditis, this question was there. So explain how to do ESR. So actually what is like, you have to collect the patient's blood. Okay, then you have to add the solution and fill the whole tube and just put it vertically at room temperature, and then after an hour you will see, due to this ESR solution, the RBC does just break, hemolysis happens, and the RBC sedimentations fall. Okay, and you're going to calculate, measure that thing, and that is called the ESR. So here my station is ending. So thank you so much. This was a really small station. These two are really small stations, but are really important stations. So is there anyone, do you have any questions? If you guys do have any question, you can just knock me on the Facebook page whenever I will be available, and as soon as I possible, I will answer you. Or you can ask me on Telegram. So, is there anyone? Any question or anything? Okay, so thank you so much. I would like to end today's session here, and inshallah on next session we will have a mock over this, and I will discuss how we will these questions are adjusted. So thank you so much, and I will have my leave here. Assalamu alaikum.